I'm Barbara Levy. I'm an obstetrician gynecologist. I am a past chair of the RUC and a current member of the CPT editorial panel. And along with Dr. Holman, I co-chaired the E&M work group. So welcome to all of you, and we really appreciate your engagement with this because this is a work in progress, and your questions are key to our ability to refine and make this as good as we can make it. So we're going to move on to time, and I think time, as the previous question outlined, is something that may confuse payers a bit and may confuse some of the coders, but it was something we had a lot of discussion about, and many of the people on the work group and on the calls were very, very adamant that the amount of time that they spend reviewing things in advance of a face-to-face visit is as intense a service as the face-to-face visit, sometimes more intense, sometimes requires more concentration, and oh, by the way, the electronic medical record has not made that easier. In fact, it may be more difficult than it used to be 10, 15 years ago. So as we considered time, the things that we wanted to do were to eliminate the ambiguity. What exact increments are we talking about? Are we talking about some median time between these two values? So we wanted to simplify that so it was really, really clear in the code set. And then CMS opened the door to this when they did their proposed rule, which said that it was time at for the entire encounter. In other words, they were still probably talking face-to-face time, although they didn't clarify that. But they had taken out that portion that said 50% or more had to be counseling and coordination of care. And very frankly, you could argue about what is counseling and coordination of care ad nauseum. So the concept is time is time. Time has a certain level of intensity, which CMS had defined a long time ago as they looked at the values for E&M services. And so we wanted the E&M codes to be flexible, to be able to account for the patient with 2-3 family members who comes in with a stack of stuff from Dr. Google and wants to talk about all of them, none of which are relevant to the medical decision making, and none of which are particularly relevant to the patient, but you've got to go through it all. We wanted to be able to account for that and account for it in a way that didn't discount qualified healthcare professionals' time. So for 2020, for this year still, you can only use time for the office and outpatient visits when counseling and coordination of care dominates. It's more than 50% of the encounter. And only the face-to-face is counted. So that's this year. For next year, January 1, 2021, CMS has agreed to these definitions that time may be used to select a code in the office or other outpatient setting, whether or not counseling and coordination of care dominates. And time may be used for selecting the level of other E&M services, that means the non-office-based services, when counseling and coordination of care dominates. So this is where we're going to get into some confusion, because some people are going to think that this new rule applies across all E&M services, and it does not. Does not apply to home care services, domiciliary care services, other things, and that's going to be an element of confusion. It's why CPT, RUC, and our work group are looking to expand now these changes into the whole set of E&M services. But that's a work in progress, and it won't be effective by January 1 of next year. So I think it's a really important point for the specialty societies, for the payers to all understand what these rules are and are not going forward. So what is total time on the date of the encounter? And this gets to your question earlier. It includes physician or other qualified healthcare professional face-to-face and non-face-to-face time. The time spent by clinical staff is not included. So if your nurse gets on the phone and talks to the payer to pre-authorize a surgery or something else, that is clinical staff time. That has already been accounted for by the RUC and others when they've evaluated codes for surgery. But if you spend that time on the phone talking to a physician at the health plan or whatever, that is your time, and your time is your time. And it's not related to the medical decision making. And we also clarified, because we had a lot of questions in the work group about, well, so the nurse practitioner or the PA sees the patient and then decides the patient's too complicated and comes and talks to me about it, and then I see the patient, or we see the patient together, how do we account for that? And what we decided, and I hope we've clarified in the guidelines, is that you can't double dip. So we can add up the time that the nurse clinician or the PA saw the patient, and then the time that you saw the patient together, and add those. What you can't do is say, well, the nurse spent 20 minutes and I spent 15 minutes. We overlapped for 10 minutes of that, but we're going to add all of that together. Does that make sense? So a minute is a minute, and a minute face-to-face or a minute with the patient is a minute with the patient, and it can't be added that there are 2 minutes there. And we did our best to clarify that.
Right, and this is actually pretty consistent. If you look in chronic care management services, we sort of have the same type of thing, and other things, team conferences, you never count a group thing. You know, you generally don't count the same time twice.
But we did our very best in the guidelines to make that as clear as possible so that we're not discouraging that kind of team-based care. We want to encourage that, but we want to make sure that the time isn't double counted. So the total time on the date of the encounter recognizes that there's a lot of important medical service that happens in non-face-to-face activities. And it uses easy to remember increments. I mean, part of this was about making things simpler, making it easy for us to figure out what the appropriate code is. And it's based on time data that we had from past valuations. CPT had a rule that said that there was a midpoint. So if it was more than 50% of this amount, then it went on to the next code. Or there's a threshold amount, it has to be at least this much to code this. And what we decided to do, and this was based on some feedback actually from CMS, was to give very explicit ranges. From this time to this time, it's this level of code. And this again is only for use when time is what you're using to select the code. And that's an important distinction for payers to understand. This is not a typical time. This is not what we think a 99202 should take. This is if you don't have sufficient complexity to code by medical decision making, then you have an alternative. Yes. Is that a question? Oh, okay, sorry. All right, so there is not a required minimum time when you're coding by medical decision making. And we expect that most people will code by medical decision making. Most of our encounters, fortunately, are not the patient and the family that comes in with the stack of things from Dr. Google and expects us to go through all of that stuff. But at times, we do have encounters that require that. So, once again, the time or the total time on the date of the encounter for coding purposes is not the time that was used for valuation purposes. So I really want to make the CPT and the RUC process a little bit distinct. So what time you will use to choose a level of code doesn't include all the time that a physician or qualified healthcare professional might spend in assessment of that patient. We all know labs are going to come back a day, 2, 3 later, and that's going to be incorporated into your mind about what you're doing with the patient. Okay, that's post-service work. It's not included in this coding. This coding is the data service. But it's work we all do. There is some pre-service work sometimes. You catch somebody in the hall, oh, I'm sending you so-and-so to evaluate for something. You spend some time. Or you review, sometimes the labs come in advance few days in advance those practices that do labs before an encounter. And you're going to glance at them and think about them and incorporate that into your medical decision-making, perhaps. So the times used for valuation include times 3 days before and up to 7 days after, but that's typical work that qualified healthcare professionals do. It's not the work that we're doing on the date of the encounter. Is that helpful? Okay. So here are the things that might happen on the date of an encounter that would be counted towards total time. Preparing to see the patient, you review the chart, you look at tests that might have come in, obtaining and reviewing separately obtained history. So face-to-face, or you're reviewing the history that your nurse got or the MA got. And fortunately now you don't have to document that again, but you will have to review it. Performing a medically necessary and or appropriate examination. So it may be that you've got all the data that you need and you examined the patient last week or 2 weeks ago and you don't have any expectation that that exam will have changed. So you don't do any examination. That's okay. That's okay. And certainly as an obstetrician gynecologist, to get to a high-level visit, I don't have to look in their ears anymore, because that really didn't impact my medical decision-making about her gynecologic condition. So we've simplified these things to be what's medically appropriate. And yes, you have to document what's important to document. So, for Dr. Holman's patients who are geriatric patients, their family history of, pick one, diabetes, hypertension, cancer, probably not terribly relevant if they're already 90 years old or 95 years old. So he didn't have to go into all of that in assessment of his patient. So all of those bullets, review of systems, history, all the examination bullets are eliminated. And that's one of the key changes that we did. And then counseling and educating the patient, the family, the caregiver, all of those things are included elements in what you might do that day. You might order medications, tests, or procedures. You might refer or communicate with other healthcare professionals. You might include all of your clinical information and documentation in the electronic record. So again, we heard about pajama time. We heard about how much time it takes in some of the EMRs to do the documentation that we need to do, and we recognize that that is work. That is relevant and stressful time that people are spending. You might spend time independently interpreting results. So in my specialty, that would be I pull up the ultrasound and I'm looking at the images myself. Even though I have a report, I'm looking at the images because I may need some piece of information from those images to plan my surgery that wasn't discussed by the radiologist, for example. And then care coordination that's not separately reported. So the key here is that anything that you report separately, if I did the ultrasound in my office and I separately reported it, that doesn't count. Okay, that's a separate encounter. If I'm looking at the images that someone else interpreted and I'm looking at them again, that's included in this time. Okay, so what are the times? What we did was review what the typical times were for 2020, looked at total time, and tried to make the increments easily memorable, right? So, and we also understood that the increments may not be equal. In other words, the difference in work between low-level decision-making and between moderate and complex might not be the same. And the time that it takes might not be the same. So here's what you have. Currently, there's 10 minutes in a 99201, and that's been deleted. For 99202, we've talked about whether we even eliminate the time for that, because the truth of the matter is the patient walks in the door as a new patient. You've reached a level of medical decision-making that you can code. So why do we even have time in there? That's a good question, and we'll hash that one out. But for now, it is 15 to 29 minutes. 203 is 30 to 44 minutes. 204 is 45 to 59. So they're 15-minute increments here with a range. And again, based on CMS's confusion about some of these things, we made the ranges really explicit. For the return visit codes, 212 they're 10, 20, 30, 40, basically. Pretty easy to remember. You have to reach through 19 minutes to go on to the next level code. Okay, so 15-minute increments for the new patients, 10-minute increments for the return visit patients, pretty straightforward. But you can think about, for example, to get to our concept about when do you use time and when do you use medical decision-making, you can think about an awful lot of patients who would rise to the level of moderate medical decision-making that might take less time, total time in the day, than 39 minutes.
Now, you'll note that the last range is not just 10 minutes, and Dr. Levy's going to tell us why.
I'm going to go through first some of the revisions
yes,
here.
Right now.
Not this minute. It's a dangling question,
yes.
Right? So, again, remember, and as you're teaching, that the allocation of time is going to be different across office and other outpatient E&M services, the 99202 through 215, versus the other outpatient services. And that's going to be a source of some confusion to people this next year. We very much hope to eliminate that confusion with the support and help from CMS moving forward, but for OBS codes and other outpatient services, it's still going to be that you use time based on greater than 50% counseling and coordination, and total time in the office and other outpatient E&M services. So if I were teaching this, I would probably teach this section as completely separate from all the others and make that as clear as I could with color coding and everything else, because I think it is going to be somewhat confusing. So the reason the increments are a little bit different is that we did incorporate CMS's proposal for a shorter prolonged services code. And what does that mean? That means that we should be able to recognize the additional work that qualified healthcare professionals are spending when they're spending a lot of time either coordinating care or working through something. So we identified the need for that prolonged services code to capture those patients. And we agreed that a shorter time was needed. So for 2020, prolonged services is still a little bit complicated. And as somebody in my practice who almost never used them, I wasn't that familiar with them, because it was just very, very rare that we would use them. But there are prolonged services codes for direct patient contact, for without direct patient contact, for the first hour, additional 30 minutes. And currently, prolonged services of 30 minutes or less beyond what's now called the typical time is not separately reported. If the criteria are met, meaning more than 30 minutes, either the face-to-face code, the 354, or the non-face-to-face can be reported on the same data service currently. Effective January 1st, 2021, we'll have this shorter code to capture 15-minute increments. So less than 15 minutes, you don't code it. 15 minutes to 29 minutes, you code it once, and we have another table to describe all of that. But as you think this through, this prolonged services code will only be used when you're coding by time, and it will only be used with the level 5 codes, because otherwise you have a way to describe it. So it gets much simpler than it has been in the past. Because in the past, you're talking about, well, it's only a 212 visit in terms of medical decision-making, but I spent all this time, so I'm going to, do these other codes. And that was a restriction because you could only use time for medical decision-making, or you could only use time when greater than 50% was counseling and coordination of care. So this prolonged services code is used only with a 205 or a 215. And again, it's 15-minute increments to code it. It allows for either face-to-face or non-face-to-face. So now you don't need two separate codes, whether you're in contact with the patient directly or you're doing a lot of coordination when the patient's not there. And we heard loud and clear from a lot of folks in the input phase of development of all these things that a lot of the time often is spent when the patient's not there in front of you, that you're coordinating, that you're doing things when they're not there. Because this add-on code, this prolonged services code, includes either one, you would never report 99354, the face-to-face prolonged services code, or the 99358, the non-face-to-face, on the date of the encounter. Does that make sense? You have this other code to use that's either face-to-face or non-face-to-face. So those two codes would not be used on the date of the encounter. But let's say a whole pile of records comes in a week later, 5 days later, and you spend 45 minutes slogging through all those other things because you're a referral center and you got all the records in and you've spent all of that. The 99358, which is the non-face-to-face prolonged services code, may be used in conjunction with that visit to report those services that you have done. Does that make sense? Now, it has to be more than 30 minutes of non-face-to-face, and I would personally recommend that you really document that, and you document why you were doing it, so that the auditor will understand that difference. And I will be frank with you that right now, CMS is a little confused about CPT recommendations about this because they've considered that the 7 days after is part of the whole thing. That was true for valuation for the typical patient. The typical patient does not have records that get dumped on you that take 45 minutes for you to review. So this code is specifically for that situation in which you're spending considerable time in the post-service time frame reviewing a lot of work.
Right, and if you read the non-face-to-face or the without direct contact prolonged services 99358, it talks about it must be related to a face-to-face service. It doesn't even have to be an E&M service. It could have been another type of service. But it's 30 minutes on a date separate. And so people have confused our CPT language of in conjunction with, which means on the same encounter by the same professional, with in relationship to, or the way we did the RUC survey. And those are different concepts. So as Dr. Levy said, doing 30 minutes or 31 minutes or 45 minutes or 2 hours or whatever on a date other than the date of the face-to-face encounter is not typical. It's not built into the valuation. And just because it's related to a service doesn't mean it's precluded by a statement that says don't report 99358 in conjunction with the office visit code, because that would mean on the same date.
So this just goes through for you what the actual language is that describes prolonged services using the 99XXX only in conjunction with the 99205 or 99215. So there's a parenthetical there that makes it really clear. A second one that says don't use it in conjunction with the 354, the 355, the 358, and do not use it for less than 15 minutes. So then we have a table to help us because we all need that help. And this just describes the minutes related to the service. So if a typical 205 is 60 minutes and it can get you The 15 minutes gets you up to 75. If you've done more than 75 minutes, you can add 1 99XXX. If it's more than 90 minutes, you can add 2 XXX. And we've already heard from some people that some of this is confusing, so we will do our best in the guidelines and in the language to make it as clear as possible how this all plays out. And then again, for the return visit codes, similar. Prolonged services is still 15 minutes, whether it's a new patient or a returning patient.
But notice the total times are different because you're starting with a different base code.
Right.
That's the thing that's very conceptually different. It does depend upon the time of the highest level base code.
So this is another table that just walks through a timeline, how many minutes, and how you would code. So a different way of looking at the same thing, but describing the coding for people. And to an earlier question about how do you decide whether you're going to code by time or code by medical decision making, something like this that you post might be really helpful because it'll just point out how much time would go into a 204 or a 205. It's a fair amount of time. And generally your medical decision making will get you to that level in less time than that. And you have all of these things. So, what are the changes here? Again, the revisions. It's a prolonged service that's with or without direct patient care. So a little bit of simplification there. That the existing codes are for other E&M services, but not for 99215 and 205. And that there are revised prolonged services with direct patient contact and prolonged services without direct patient contact in the guidelines. So we've written into the guidelines to try to make it clear when you use which prolonged services codes. But the really bottom line is the new code is for the office E&M services, and the others are for the other services, except when you've got non-face-to-face in the post-service time. Okay, so what did CMS decide? And we were sweating bullets, I have to tell you, after all of this work. So CMS did finalize the decision to adopt the CPT proposal for 99XXX to report the prolonged time spent on the date of the primary office or other E&M visit. But like all of us, CMS got a little confused about the reporting guidelines for 99358 and 359. And we will spend time with CMS, both in written and in face-to-face visits with CMS, for which we may have to report prolonged services, trying to clarify all of this, trying to clarify why this makes sense and how it makes sense. But for now, CMS has finalized Medicare 2021 saying that 99358 and 359 will not be reportable with other office and outpatient E&M services. So again, as Dr. Holman and Dr. Jagman mentioned earlier, a lot of this is a work in progress, and some of this in the fine print here, I don't want you to take home and start teaching because it may not be the final. I mean, there's another year here where CMS can revise some of this. And so we've tried to make it clear which things, yes, go teach these things because they're important. Total time, medical decision-making, the charts, those things, yes. Some of these nuances I probably would not incorporate into teaching right now because we're not clear about how they're going to play out over this next year. So all of this got done in time to send it to the specialty societies to do surveys. And let me go through what the RUC recommendations are because we've been referring to this for quite some time. We had an incredible participation in this survey process. 51 specialty societies and other professional organizations surveyed the revised codes. That is the largest RUC survey that I can ever recall, and I think it is the largest. And 1,700 physicians responded to the survey. And those of you who know the RUC process, that's an incredibly robust survey for the RUC to have dealt with. The surveying specialties analyzed their data and presented the recommendations to the RUC in April of 2019. And the RUC recommendations got submitted to CMS in time for CMS to consider them for the final rule. So that was an amazing amount of work by physicians and specialty societies and staff all across the board. It was an incredible push, much of which was done to try to prevent that collapse of the payment, because we all recognized what kinds of inequities that would create, not only for the provider community, but actually for our patients. That when you get paid the same for treating a hangnail as for managing a cancer patient, that's going to create a lot of access problems and time problems for patients who really need our time and really need our efforts. So, for calendar year 2020, the physician final proposed rule, I should say, announced their decision to implement the CPT framework and the RUC recommended valuation for January 1, 2021. And there's a link there for you if you want to see what the RVUs are. Here's a chart for you. So no change in 202. 203 goes up from 1.42. And these are the work values. This isn't the total RVUs. To 1.6, 204 goes from 2.43 to 2.6. 99205 goes from 3.17 to 3.5. And for the return visit codes, no change in 211. As we've said, we don't think the work there has changed. 212 goes from 0.48 to 0.7, and you can see the rest. I don't need to read them to you. But these are substantive changes in evaluation and management services. And the value for the 99XXX is 0.61. So the RUC also recommended, based on the surveys that came from the surgical specialties, procedural specialties, that all of these new evaluations be incorporated into the 10 and 90-day surgical global. CMS chose not to do that. CMS had a lot of language in the final rule, and that is something that is the effort and an advocacy focus for AMA in conjunction with the specialty societies over this next year, and a really important refinement to retain relativity across the fee schedule. And what you'll see is a lot of discussion from CMS about, well, we're not sure how many of those visits actually happen or what they are, but it's very clear that there's evaluation of the patient before a surgical or procedural encounter. And so there'll be a lot of advocacy related to this decision by CMS over the next year, hopefully over the next actually several months, so that we can see something in a proposed rule that will guide us.